The cardiac cycle. The cardiac cycle refers to the filling and emptying of the heart's chambers. The cardiac cycle has two phases: diastole, relaxation of the ventricles, known as filling, and systole, contraction of the ventricles, known as emptying. Diastole endures for approximately 2/3 of the cardiac cycle, and systole is the remaining 1/3. During ventricular diastole, the AV valves are open and the ventricles are relaxed. This causes higher pressure in the atria than in the ventricles. Therefore, blood rushes through the atria into the ventricles. This early, rapid, passive filling is called early or protodiastolic filling. This is followed by a period of slow, passive filling. Finally, near the end of ventricular diastole, the atria contract and complete the emptying of blood out of the upper chambers by propelling it into the ventricles. This final active filling phase is called presystole, atrial systole, or sometimes the atrial kick. This action raises left ventricular pressure. Systole. The filling phases during diastole result in a large amount of blood in the ventricles, causing the pressure in the ventricles to be higher than in the atria. This causes the AV valves, mitral and tricuspid, to shut. Closure of the AV valves produces the first heart sound, S1, which is the beginning of systole. This valve closure also prevents blood from flowing backward, a process known as regurgitation, into the atria during ventricular contraction. At this point in systole, all four valves are closed and the ventricles contract, isometric contraction. There is now high pressure inside the ventricles, causing the aortic valve to open on the left side of the heart and the pulmonic valve to open on the right side of the heart. Blood is ejected rapidly through these valves. With ventricular emptying, the ventricular pressure falls and the semilunar valves close. This closure produces the second heart sound, S2, which signals the end of systole. After closure of the semilunar valves, the ventricles relax. Atrial pressure is now higher than the ventricular pressure, causing the AV valves to open and diastolic filling to begin again. Heart sounds are produced by valve closure, as just described. The opening of valves is silent. Normal heart sounds, characterized as lub-dub, S1 and S2, and occasionally extra heart sounds and murmurs, can be auscultated with a stethoscope over the precordium, the area of the anterior chest overlying the heart and the great vessels. Normal heart sounds. The first heart sound, S1, is the result of closure of the AV valves, the mitral and tricuspid valves. As mentioned previously, S1 correlates with the beginning of systole. S1, lub, is usually heard as one sound, but may be heard as two sounds. If heard as two sounds, the first component represents mitral valve closure, M1, and the second component represents tricuspid closure, T1. M1 occurs first because of the increased pressure on the left side of the heart and because of the route of myocardial depolarization. S1 may be heard over the entire precordium, but is heard best at the apex, left MCL, fifth ICS. Understanding normal S1 sounds and variations. S1 which is the first heart sound, is produced by the AV closing. S1, the lub portion of lub-dub, correlates with the beginning of systole. The intensity of S1 depends on the position of the mitral valve at the start of systole, the structure of the valve leaflets, and how quickly pressure rises in the ventricles. All of these factors influence the speed and amount of closure the valve experiences, which, in turn, determine the amount of sound produced. Normal variations in S1 are heard at the base and the apex of the heart. S1 is softer at the base and louder at the apex of the heart. An S1 may be split along the lower left sternal border, where the tricuspid component of the sound, usually too faint to be heard, can be auscultated. A split S1 heard over the apex may be an S4. Accentuated S1. An accentuated S1 sound is louder than an S2. This occurs when the mitral valve is wide open and closes quickly. Examples include hyperkinetic states in which blood velocity increases, such as fever, anemia, and hyperthyroidism. Mitral stenosis, in which the leaflets are still mobile, but increased ventricular pressure is needed to close the valve. Diminished S1. Sometimes the S1 sound is softer than the S2 sound. This occurs when the mitral valve is not fully open at the time of ventricular contraction and valve closing. Examples include mitral insufficiency, in which extreme calcification of the valve limits mobility. Delayed conduction from the atria to the ventricles, as in first-degree heart block, which allows the mitral valve to drift closed before ventricular contraction closes it. Delayed or diminished ventricular contraction arising from forceful atrial contraction into a non-compliant ventricle, as in severe pulmonary or systemic hypertension. Split S1. As named, a split S1 occurs as a split sound. This occurs when the left and right ventricles contract at different times, asynchronous ventricular contraction. Examples include ventricular ectopy, in which the impulse starts in one ventricle, contracting it first and then spreading to the second ventricle. Conduction delaying the cardiac impulse to one of the ventricles, as in bundle branch block. Varying S1. This occurs when the mitral valve is in different positions when contraction occurs. Examples include rhythms in which the atria and ventricles are beating independently of each other. Totally irregular rhythm, such as atrial fibrillation. The second heart sound, S2, results from closure of the semilunar valves, aortic and pulmonic, and correlates with the beginning of diastole. S2, dub, is also usually heard as one sound, but may be heard as two sounds. If S2 is heard as two sounds, the first component represents aortic valve closure, A2, and the second component represents pulmonic valve closure, P2. A2 occurs first because of increased pressure on the left side of the heart, and because of the route of myocardial depolarization. If S2 is heard as two distinct sounds, it is called a split S2. A splitting of S2 may be exaggerated during inspiration and disappear during expiration. S2 is best heard at the base of the heart. Extra heart sounds. S3 and S4 are referred to as diastolic filling sounds, or extra heart sounds, which result from ventricular vibration secondary to rapid ventricular filling. If present, S3 can be heard early in diastole after S2. S4 also results from ventricular vibration, but contrary to S3, the vibration is secondary to ventricular resistance, non-compliance, during atrial contraction. If present, S4 can be heard late in diastole, just before S1. S3 is often termed ventricular gallop, and S4 is called atrial gallop. Variations in S2. The S2 sound depends on the closure of the aortic and pulmonic valves. Closure of the pulmonic valve is delayed by inspiration, resulting in a split S2 sound. The components of the split sound are referred to as A2, aortic valve sound, and P2, pulmonic valve sound. If either sound is absent, no split sounds are heard. The A2 sound is heard best over the second right ICS. P2 is normally softer than A2. Accentuated S2. An accentuated S2 means that S2 is louder than S1. This occurs in conditions in which the aortic or pulmonic valve has a higher closing pressure. Examples include increased pressure in the aorta from exercise, excitement, or systemic hypertension. A booming S2 is heard with systemic hypertension. Increased pressure in the pulmonary vasculature, which may occur with mitral stenosis or congestive heart failure. Calcification of the semilunar valve, in which the valve is still mobile, as in pulmonic or aortic stenosis. A diminished S2 means that S2 is softer than S1. This occurs in conditions in which the aortic or pulmonic valves have decreased mobility. Examples include aortic or pulmonary stenosis, in which the valves are thickened and calcified with decreased mobility. Decreased systemic blood pressure, which weakens the valves, as in shock. Normal, physiologic split S2. A normal split S2 can be heard over the second or third left ICS. It is normally heard best during inspiration and disappears upon expiration. Over the aortic area and apex, the pulmonic component of S2 is usually too faint to be heard, and S2 is a single sound resulting from aortic valve closure. In some clients, S2 may not become single on expiration until the client sits up. Splitting that does not disappear during expiration is suggestive of heart disease. Wide split S2. This is an increase in the usual splitting pattern that persists throughout the entire respiratory cycle and widens on expiration. It occurs when there is delayed electrical activation of the right ventricle. An example, right bundle branch block, which delays pulmonic valve closing. Fixed split S2. This is a wide splitting that does not vary with respiration. It occurs when there is delayed closure of one of the valves. An example, atrial septal defect and right ventricular failure with delay pulmonic valve closing. Reversed split S2. This is a split S2 that appears on expiration and disappears on inspiration, also known as paradoxical split. It occurs when the closure of the aortic valve is abnormally delayed, causing A2 to follow P2 in expiration. Normal inspiratory delay of P2 makes the split disappear during inspiration. An example, left bundle branch block. Accentuated A2. An accentuated A2 is loud over the right second ICS. This occurs with increased pressure, as in systemic hypertension and aortic root dilation, because of the closer position of the aortic valve to the chest wall. Diminished A2. A diminished A2 is soft or absent over the right second ICS. This occurs with immobility of the aortic valve and calcific aortic stenosis. Accentuated P2. An accentuated P2 is louder than or equal to an A2 sound. This occurs with pulmonary hypertension, dilated pulmonary artery, and atrial septal defect. A wide split S2, heard even at the apex, indicates an accentuated P2. Diminished P2. A soft or absent P2 sound occurs with an increased antero-posterior diameter of the chest, barrel chest, which is associated with aging, pulmonic stenosis, or COPD, chronic obstructive pulmonary disease. Blood normally flows silently through the heart. There are conditions, however, that can create turbulent blood flow in which a swooshing or blowing sound may be auscultated over the precordium. Conditions that contribute to turbulent blood flow include 1. Increased blood velocity, 2. Structural valve defects, 3. Valve malfunction, and 4. Abnormal chamber openings, e.g., septal defect. Auscultating heart sounds. Most nurses need many hours of practice in auscultating heart sounds to assess a client's health status. Practitioners may be able to recognize an abnormal heart sound, but may have difficulty determining what and where it is exactly. Continued exposure and experience increases one's ability to determine the exact nature and characteristics of abnormal heart sounds. Where to auscultate. Heart sounds can be auscultated in the traditional 5 areas on the precordium, which is the anterior surface of the body overlying the heart and great vessels. The traditional areas include the aortic area, the pulmonic area, Erb point, the tricuspid area, and the mitral or apical area. The 4 valve areas do not reflect the anatomic rotation of the valves. Rather, they reflect the way in which heart sounds radiate to the chest wall. Sounds always travel in the direction of blood flow. For example, sounds that originate in the tricuspid valve are usually best heard along the left lower sternal border at the 4th or 5th ICS. Traditional areas of auscultation. Aortic area, 2nd ICS at the right sternal border, the base of the heart. Pulmonic area, 2nd or 3rd ICS at the left sternal border, the base of the heart. Erb point, 3rd ICS at the left sternal border. Mitral apical, 5th ICS near the left MCL, the apex of the heart. Tricuspid area, 4th or 5th ICS at the left lower sternal border. Alternative areas of auscultation. In reality, the areas described overlap extensively, and sounds produced by the valves can be heard all over the precordium. Therefore, it is important to listen to more than just 5 specific points on the precordium. Keep overlap in mind and use the names of the chambers instead of Erb point, mitral, and tricuspid areas when auscultating over the precordium. Alternative areas of auscultation overlap and are not as discrete as the traditional areas. The alternative areas are the aortic area, pulmonic area, left atrial area, right atrial area, left ventricular area, and right ventricular area.